I think over the next 6 to 12 months, a number of things need to happen. Nationally, I think it would be it's essential that we bottom out the duty of candour so that everyone knows what that means. Because I think there's a considerable level of uncertainty, and it is an extremely important part of what needs to happen for patients. I also think we need visible progress. There's been a lot of progress already, but we need to continue the progress with regard to information about how the service is being delivered at all levels. And finally, we need to get out there whatever fundamental standards are going to be defined as a result of the Care Quality Commission's consultation. I think those are the main things I'd like to see, in addition to what's happening so far at national level. And obviously there's a concern with an election coming up that the impetus in all this can be lost. But I hope with the commitment the government is currently showing that that won't happen. I think at local level, I'd like to see more effective involvement of patients in what trusts and commissioners are doing. Some are much better at this than others, that's one thing. The other is a much wider spreading of the practice we see in places like Salford about how to make sure that the right staff are in place to look after patients. And I would very much like to see the Secretary of State's agenda fulfilled in relation to having named doctors and named nurses all the time for every patient, because I think with that sort of professional identification and responsibility and accountability, we'll be treating patients as people as much as a problem, or rather than being a problem. I think by and large it is. I think this Nuffield Trust report is really encouraging from that point of view. The vast majority of respondents tell us that they are making changes as a result of the report, and that reflects the conversations I've had up and down the country in the last year. I've been really impressed by the level of commitment and enthusiasm, particularly amongst frontline professionals, a feeling that they are much freer than they have been before to raise issues and get them dealt with. And after all, that's what this will really sort any problems there are. It's the professionals at the front line who know what's wrong, they know what needs to be changed, and they need to be listened to. And patients who've suffered things badly also need to be listened to, because the learning that they offer is immense, apart from the harm that's done by not listening to them personally. Well, one of the main challenges, as always, is the complexity and size of the NHS, which brings about with it an inertia. And so unless the beast is continually prodded, it will stop moving. And in order, changing a culture is not just a question of turning on a switch. It is a continual process. And once you've got there, you've got to keep at it. So I think that's the principal challenge. Everyone always murmurs, but very few dare to talk very loudly about the tensions between perceived financial constraints, which have become very real, and the delivery of quality. My reaction to that is to say that there is very rarely a dichotomy between the two. Good quality, safe and effective care, all the evidence shows, costs less than poor care. And my experience as a clinical negligence lawyer tells me every day how expensive the bill is when that doesn't happen. So do it right, it'll be more cheap, it'll be cheaper. But where that's not the case, where financial constraints genuinely get in the way of, say, the right number of staff, then organisations have got to be open and honest about that and say they cannot do what they cannot do. What's unacceptable is to pretend that you can deliver a service to an acceptable standard when you can't. But having said that, most of what I found at Mid Staffordshire was about things that just shouldn't happen anywhere. They were about patients being left in faeces, not being fed, about surgical staff not cooperating with common procedures, about fabricating notes in accident and emergency departments. These aren't things that are about money. They're about behaviours and learnt behaviours. And if we actually solved those, I actually think the money would look after itself. I think that the vast majority of people in the NHS, whether they, and I include in that the regulators and the Department of Health as well as people at the front line, they came into this business in order to help people, and they see this as an opportunity to do that a lot better than they've been able to do in the past. So I think there is a real determination there. That could disappear quickly if the wrong messages are sent out by the inappropriate leaders in different places. But I do hope that's not going to happen. On the whole, I'm optimistic.